Good afternoon. In order for us to be here today, we had to convince 8 Democratic senators to vote to reopen the government so that we had air traffic control available to bring everyone here to San Francisco. And we also tried to arrange a little better weather than we had here yesterday. So we're really so excited to have you all here joining us for now our 4th INNOVATE Ocular Oncology meeting here in Palo Alto. INNOVATE is part of a environment of meetings that we have put together through our Stanford Department of Ophthalmology, along with my co-retina faculty members Diana Doe, Quan Nguyen, and Stephen Smith. We've ventured into areas of uveitis, retina, as well as ocular oncology, which we think is the best of all of our meetings. Nothing happens today without really my very good friends and colleagues who have ventured from around the country and around the world, as well as some of our very talented students and researchers here in our group as well. It's really an illustrious group of experts that are bringing a wealth of knowledge that I look forward to learning from because they teach me something every time we're here. When I asked them to come and speak and what topics to give, I said, just give me your latest and greatest stuff. And I think they've all come through in spades because the topics just look fantastic. What I ask is that this is a meeting to show sometimes new stuff, undeveloped stuff, new ideas. It's meant to forge conversation, discussion, respectful disagreement. But this is a really open and should be a friendly environment. So we hope at the end of it, it brings up new ways to take care of our patients as well as forging new collaborations. This year we opened abstracts up to folks to present some of their original work, and we thank all of the young and more senior contributors who have brought forth some of their interesting work. And this doesn't happen without the ecosystem of clinicians working with scientists, working with industry, which in ocular oncology, it's kind of like a golden era right now where we have such interest with biopharma, many in our backyard here in the Bay Area, that are really working to move therapies from just pipe dreams to concepts to patients, and hopefully through the approval process. So just know that as clinicians, we are here to support that process, and we thank you for supporting our ability to learn. Program evaluations, we'll put this up again tomorrow. This should be a meeting for all of us to be able to learn what we want to learn. So if there's ideas that you have, we are open to it. We have a great team from iVista who have helped with all of our arrangements, and they're open for questions. There'll be mics that should be passed around. So if you have questions, just raise your hand. The room's big enough. We can probably hear you as well. So without further ado, we'll get started. My co-moderator, Dr. Tom Auberg, will start us off.
Thank you, Prithvi. First speaker is known to probably everyone in this crowd. Carol Shields will be presenting Virtual Visits in Ocular Oncology, the New Era. Carol?
Thanks, Tom. I have no financial interest or relationships to disclose. Can you believe we're going to be talking about virtual visits in ocular oncology, and not just one paper, but multiple papers in this session? Can it really be done? And I'd like to give support to our foundations that have supported us, including the Jerry A. Shields MD Eye Cancer Fund. Well, we have new avenues in ocular oncology. We have ocular tumor monitoring by cell phone detection, phone photography, text consultation, virtual monitoring, and digital everything. So I'm going to talk about virtual monitoring in ocular oncology. Virtual monitoring, how does it work? Well, devices collect health metrics. The data is transferred to an MD on a secure network, HIPAA approved. It must be HIPAA approved. And the MDs analyze and respond in real time. And in general medicine, patients will wear like a fitness tracker or a smart device for diabetes. and then they visit the telehealth offices for examination. And there's numerous telehealth companies, and they all have their various setups for their telehealth monitoring. And in general medicine, telehealth has a lot of benefits. Patients have easy access near home, improved detection of health problems, reduced travel for the patient, and reduced cost for the patient. And in this one diagram, they give 13 benefits of telemedicine. Not all of them apply to us, but number one, support for people with chronic conditions like choroidal nevi. Or number three, reduced exposure to viral pathogens in the office. Or number 7, middle of the night care. No, we don't give any middle of the night care. But number 10, lower cost. And number 12, insurance reimbursement. And number 13, medical access for patients in rural areas. So in ophthalmology, there are advantages to the patient. It's easier, more convenient patient care. There's no traveling in traffic or expensive parking or hotel stay overnight or no long time waiting. And it spares time from work for the children of especially elderly people. And there's many more benefits. For example, in ophthalmology, if you go to a small community, you can get a cheaper office, less expensive than that expensive footprint that you might have in a downtown district like Philadelphia. Now, there are some disadvantages to teleophthalmology. You need technology access. There's a risk of hacking. You have strict HIPAA compliance issues. You need a good internet, and you have to have a license in that state where you're going to practice. And of course, there are going to be startup costs and ongoing costs. And keep in mind, some persons do need in-person care, and some doctors do misinterpret the digital information. So what are the startup costs for ophthalmology, particularly ocular oncology? Well, you have to purchase devices, purchase software. You need a digital wizard, someone in your office who knows how to troubleshoot problems that might happen, staff training, and I think it's in some cases, it can cost up to $300,000, $400,000, or even $500,000 per site of digital telehealth office. So what have we done? Well, we have purchased cameras for 3 different sites. We've purchased a Claris, an ultrasound UBM, an OCT, a slit lamp, and we don't have an external camera. We use an iPad for all external photographs. And we have 2 personnels who go to our telehealth offices, 1 technician and 1 photographer. And the technician does the vision, pressure, ultrasound, and UBM, and the photographer does the external slit lamp, fundus, and the OCT. And when do we do virtual? Because we're really a busy practice. Well, I see virtual patients on clinic days and on OR days. On clinic days, I see them in between seeing live patients. It's fast, and our virtual patients love it. And on the OR days, I'll see them typically after I operate, after the OR is done. And we see on average 40 to 60 patients on follow-up virtually per week. Many benefits to the patients. Patients will save $500 to $1,000 per patient because they don't have to drive, pay tolls, park, stay overnight at a hotel, etc. The appointment's fairly easy and the care is fairly easy with pretty rapid speed of appointment and little exposure to other patients. So how do we do it? Well, this is how we do it. We have 1 fellow who preps the charts the week before. When the patient arrives in the virtual office with free parking, the technician will take the vision, pressure, ultrasound, and if needed, a UBM. The photographer does all the imaging of the macula, the tumor, ASOCT as needed, and then the technician will call our tele-coordinator in our office who fills in the vision, pressure, and interval history. And then in our office, we keep the chart there. We Zoom connect with the patient. The patient watches as we review all of their images. We annotate the chart, we dictate the letter, and then we Zoom talk to the patient. And then the patient gets their appointment sometimes with a QR code, or we call and set up their appointment if they aren't comfortable with QR codes. So here you can see me in our kitchen, in our office. We have iPads all set up. I'm reviewing iPads in front of a patient who's watching me do the review. Usually I have a couple of technicians with me. We have a special software called Continuum that allows us to see all the various dates that the patient was seen. This is on an iPad. And then I have comparison of the date first seen in 2019 of the melanoma on the left with today's date with the melanoma regressed on the right. And we also have comparison of the melanoma on the left, date first seen, with the melanoma today when the ultrasound was gathered, showing regression, and even the OCT, date first seen versus today. Then we document this in our chart, and I can talk to you later about paper charts with which I prefer over EMR because it's so down to the exactly what you need. So virtual live visits, we see 20 to 25 per day, sometimes up to 60 per week. Free parking, easy access, closer to home. We always have it on the first floor in case they're wheelchair bound. And it takes often less than 60 minutes and patients really enjoy it. So I'll finish with, have we ever published on this? And the answer is yes. So we published in the Canadian Journal of Ophthalmology 2023 patient perspectives on ocular oncology care at hybrid telehealth offices. And in the bottom, underlined in red, you can see most patients, 90%, would use the telehealth office model again, and most patients, 86%, would recommend it to a friend. So patients basically, if they're under age 70, prefer telehealth offices. Now we're conducting a larger survey on over 5,000 patients that we've seen in telehealth offices. And then Ezekiel Weiss also wrote in the Canadian Journal of Ophthalmology just this year on teleophthalmology. And he had 96% of his patients responded to the survey, and they found a very high satisfaction in his patients. There's a lot on the internet about telehealth, so I think telehealth is here to stay. So in conclusion, virtual telehealth visits are a powerful approach to improving healthcare delivery with improved access to patient care. It's less expensive for the patient, a little bit of startup costs, and it's a new strategy of care. And I think it's an integral part of the modern healthcare system. And I think the days of waiting hours and hours to see Dr. Marr is over. Thank you.
Our next speaker is Scott Walter from Connecticut, discussing imaging-only surveillance for low-risk melanocytic lesions. Scott.
Thanks, Prithvi, and thanks, Carol, for kicking off the session. So I'm going to share a little bit about what I've been doing kind of in a similar vein, using imaging-only surveillance visits for low-risk melanocytic choroidal lesions. Here are my disclosures, none of which are really relevant to this talk. So, why is surveillance necessary? We know the molecular biology of these melanocytic lesions. They all possess the GQ pathway activating mutations, which increase the rate of cellular proliferation, and subsequent mutational events or PRAME activation or chromosomal aberrations can thereafter drive malignant transformation. So these low-risk lesions may be low risk, but they're not no-risk lesions. The risk of malignant transformation appears to increase with age, and a history of stability does not guarantee future stability. So here's an example. This is a 80-year-old retired university professor who was followed for 30 years in Boston by Grigutis and later Mattern at Yale for a benign choroidal nevus. And when Dr. Mattern left Yale, the patient decided, you know what, there's no one else to see in Connecticut. I'm just going to, see my regular ophthalmologist once every couple of years. And he gets referred to me 5 years later with what is clearly a tumor that's undergone malignant transformation. You can't necessarily see here, but this is a fairly large tumor. A patient ended up undergoing enucleation. So all melanocytic lesions I think of as potentially pre-malignant. They require lifelong surveillance by someone, ideally a tumor specialist. So what are the core modalities we use? So I call this multimodal tumor imaging. The workhorse modalities are fundus photography, EDI OCT, and AB scan ultrasound. And in select cases, we may use angiography with dye-based or OCT-based techniques, as well as ultrasound biomicroscopy. What we're looking for across these different modalities, I don't need to tell everyone in this room: diameter, thickness, lipofuscin, pigment, a subretinal fluid, and changes in internal reflectivity and internal vascularity on ultrasound. And of course, the different imaging modalities have different strengths in terms of detecting change in these aspects of the tumor. But if we had to choose just one modality, I would choose fundus photography. And the reason is it really assesses multiple growth parameters, the growth in 2 dimensions, at least potentially 3 dimensions to some extent. It's easy with fundus autofluorescence imaging to detect changes in orange lipofuscin pigment, which is hyperautofluorescent, as well as these hyperautofluorescent watermarks, which generally correspond to the presence of microscopic exudative retinal detachments or subretinal fluid that we see on OCT. So why ultra-wide field fundus photography? It captures growth, metabolic, and exudative aspects of the lesion. It's easily acquired without dilation. You can train pretty much anyone to take an Optos photo with about an hour of education, and you can get these high-quality, highly reproducible images. Also, the software that's built into the Optos platform is very easy to use for comparison. I'll show you some examples in a little bit. We capture the entire lesion as well as the surrounding retina. So we have lots of other landmarks we can use to assess the size of the lesion and whether the image may be stretched. So my practice philosophy has evolved over the last several years in terms of how to structure surveillance. When I started off, I wanted to see all of these nevus patients and build my practice, but pretty soon it became super overwhelming to have, so many B scans in every clinic day, and it was becoming a real bottleneck. So now what I do is basically at baseline, I have an initial visit with a comprehensive eye exam, full multimodal tumor imaging, and then I risk stratify the lesion from anywhere from very low risk to high risk lesions. And the surveillance plan, of course, depends on the risk profile of the lesion at that baseline visit. Most lesions are reviewed every 6 to 12 months, alternating between a full exam with multimodal tumor imaging and an imaging-only visit to improve clinic efficiency. So here's the workflow. If a patient comes in for an imaging-only visit, they complete a brief pre-visit questionnaire just attesting that there's no visual symptoms or other changes in their medical history that might necessitate an in-person exam. The staff then obtain the ultra-wide field fundus photo and fundus autofluorescence with attention to the quadrant where the tumor is located, and the patient leaves. Later in the day, they'll load the images in an empty exam room, and in between patients, if I have time, I'll pop into the exam room, review the images, and just check the form that nothing changed. That's 95% of the time, and in this case, I don't speak to the patient. We just bill for fundus photography, and the staff call the patient at the end of the day to let them know everything looked okay. We'll see you in 6 months or a year for your next exam. If there are possible changes detected on the fundus photo, then I will complete a telehealth visit with the patient to review those findings, discuss the potential implications. This is a recorded visit that is AI summarized, and our virtual scribe will listen to it and then complete the chart. And we bill for a fundus photo and telehealth visit, usually a level 3 INM with a 95 modifier. And then the office staff will arrange a near-term comprehensive eye exam in person with multimodal tumor imaging to reevaluate the lesion. So for a typical low-risk choroidal nevus, we have the baseline consult. 6 months later, imaging only. 12 months later, multimodal tumor imaging with a comprehensive eye exam. This repeats in year 2. And then after 2 years of lesion stability, we may extend this patient to annual follow-up, again, alternating between imaging only and multimodal tumor imaging. So over the past 2.75 years, I completed 3,350 encounters with an ICD code for nevus, and basically half and half between office visits with multimodal tumor imaging and fundus photos only. If we look at the time, so an initial consult on a nevus takes about 24 minutes in my clinic, about 12 minutes, so half as much time for a follow-up, and then 1.2 minutes to review a fundus photo. So basically 1/10 the time I would spend on a comprehensive exam with multimodal tumor imaging. What are the cost savings, what's the productivity for the provider? So basically this is what you get paid by Medicare for your initial consult. You're making $12 a minute. When you see that patient in follow-up, you're making $21 a minute. But if you just review their fundus photo, you're making $32 a minute. So the blended rate in terms of your productivity for this hybrid model alternating between comprehensive eye exam and multimodal tumor imaging is $22 per minute, which is pretty favorable in comparison to the cost of that or the productivity of that initial consult. Let's look at this from a payer standpoint. So if you're doing multimodal tumor imaging every 6 months, that's about $500 a year in Medicare cost. This alternative model saves Medicare $200 or 42% of the cost. And if you aggregate that at the population level using my patient volume and a 53 to 47% split, we're saving about $250,000 for Medicare a year. So pretty significant savings. So next, I'll just show a few real-world cases demonstrating how I'm actually interpreting the images. So here's an example of a partially amelanotic lesion. I'm using the calipers in the Opto software to assess the basal diameters of the lesion. And then I'm going to use the Smart Zoom functionality to create a box around the tumor, bring the baseline visit in, and then we'll do a comparison here so we can see whether the tumor has grown or changed compared to the baseline. There's a little bit of an image stretch artifact. So what I'm going to do is go back to the original visit, look at the calipers, and again, the lesion diameters are within 0.25 millimeters of each other. So I judge this lesion to have not grown over the course of this follow-up visit. Here's an example of a small tumor with some orange pigment seen on the fundus photo. So what we're going to do is overlay the fundus autofluorescence to see whether that might be lipofuscin. Indeed, it is hyperautofluorescent orange pigment, corresponding, co-localizing to the orange pigment. Now let's go back to the baseline fundus autofluorescence. You can see that orange pigment wasn't really there at baseline. And the tumor margins have not changed since baseline. You're going to see that comparison here. The only thing that's changed is the increased orange pigment. So another example of how we can use it to look at metabolic activity on the tumor surface. And here is an example of looking at that hyperautofluorescent watermark, which is increasing over the past year. And if we go back to the baseline visit on this patient, there was no hyperautofluorescent watermark there. So we're seeing new subretinal fluid overlying a lesion. So these are ways in which one imaging modality can really tell us a lot about what's going on with the patient. So in summary, the advantages are that this is appropriate for the majority of lesions that we see in clinic. It improves at some point in their follow-up after, if it's a more suspicious lesion, obviously we're going to do multimodal tumor imaging for several visits before we incorporate the imaging-only visits. It substantially reduces B-scan bottlenecks and patient wait time in clinic, decompresses my schedule so that I can do more injections and see more patients. And if the patient happens to miss an imaging-only visit, it's very easy to reschedule because we're not waiting for that next available B-scan slot, which is usually 8 to 12 weeks out. All right, so what are the advantages here? It's better for patients. They're getting surveillance with a tumor specialist rather than doing that $12 per minute consult and then sending them back to the retina specialist and hoping that they'll do a good job with the follow-up. We are able to detect subtle changes as tumor specialists that I think would often be missed in the community. It's better for us so it's better for the patient in that respect. It's better for us from a financial standpoint. It's a predictable and recurring source of revenue, and it increases our provider productivity to hold on to these patients in an efficient manner through time. And it's better for payers with a 40% savings relative to doing multimodal tumor imaging, standard of care imaging at every visit. So limitations, it may not be appropriate for all lesions or all patients. Certainly high maintenance patients I still see in the office most of the time. It may be less sensitive to detect changes in thickness and obviously things that are unique to ultrasound like internal reflectivity and internal vascularity. And this is a very problem-focused exam. So we're just looking at one thing. We may miss other issues with the eye that might warrant a comprehensive eye exam, but it does tell us an awful lot. So in conclusion, NEVA surveillance is really the bread and butter of the tumor practice, but it really takes up a lot of our valuable time. And so in order to decompress our schedules, we can use imaging-only surveillance in a structured multimodal tumor imaging-based follow-up plan that preserves specialist oversight, maintains patient safety, improves clinic flow, avoids unnecessary exams, and optimizes the utilization of expensive resources like ultrasound, which ultimately saves money. Thank you so much. Here's my contact information if anyone would like to discuss this further.
Thank you, Scott. That was fascinating. Next is going to be Lauren Dalvin. She is going to be presenting a photo screening pathway for choroidal nevus surveillance to move the same theme along here.
All right, thank you. It's so interesting how so many of us are coming to the same conclusions around the same time here. I think exactly what we've been doing is really what needs to happen for us to be able to continue to take care of these patients. These are my financial disclosures. I'm a consultant for Aura and IDEA, and I have grant support from DoD and NCI, as well as Mayo Clinic, not relevant to this talk. So I don't have to emphasize to this particular room how common choroidal nevus is, that its prevalence is about 5% or up to even 1 in 10 people, depending on where you are and what your patient population looks like in the country. And we know, many of us in this room, that even when they're very low risk choroidal nevus lesions, if we are close and available, they're probably going to get referred because people feel much better to have our opinion on record. But in reality, the risk of malignant transformation, although not zero, is quite low. So these can become a large practice burden. And there's really a need to be able to follow these in a different way than what we've been doing. There's an expected 30% shortage of ophthalmologists all around by 2035. And then if you look at the very small population that is ocular oncologists, we're really highly unavailable to do broad-based choroidal nevus screening in the traditional in-person visit sense. The American Academy of Ophthalmology has looked and reported only 142 ocular oncologists currently practicing in the United States, and these are heavily concentrated in particular areas like California and Texas. There are 17 states that at the time of this reporting had no in-state ocular oncologist. In our particular practice at Mayo Clinic in Minnesota, we have a relatively broad catchment area. So we see the vast majority of patients in Minnesota, North and South Dakota, as well as Western Wisconsin and Northern Iowa. And we also see patients from across the world who want their care at Mayo Clinic, many who are getting executive health screenings in other departments and want to add on their ophthalmology visit here. So we've been rethinking how we do our choroidal nevus monitoring. And since I've started practicing, I've been collecting data about my patients in what I've called the prospective ocular tumor study. And we published our 5-year data on this. And by and large, the most common thing I see in my practice is choroidal nevus. So I thought about how can I take these choroidal nevus patients and potentially get them out of in-person visits to decompress my clinical practice. And I looked back to risk factors that we've previously defined: thickness, fluid, symptoms, orange pigment, acoustic hollowness, and diameter. And I really leaned on these to try to create a very simple algorithm for how we could triage patients into a virtual pathway for photo screening. So when I was thinking about developing a risk stratification model, I thought about, first, am I going to be able to adequately capture these lesions on a photograph? I think that's very critically important to consider. So things that are quite anterior, although we're getting better and better with our cameras, may not be good photo screening candidates. And I was going for safety on an auto triage here. So things that were anterior to equator, I elected not to put automated into a photo screening pathway. And then I looked at the risk factors. For patients who had 0 to 2 risk factors, I said that we could go ahead and put them into the photo screening pathway. Patients who had 3 risk factors required personal review by me to determine if they would be good candidates, and patients with 4 or more risk factors were deemed too high risk to go into a virtual photo screening pathway. And so of our 614 choroidal nevi in a 5-year period and 586 patients, we found demographics similar to what we've seen historically, perhaps a slight female preponderance due to where we are in the country, mostly white patients, typically patients in their 60s, similar distribution of right and left eyes. Most of these patients don't have other eye problems. Most of them have good vision, and most of the choroidal nevi are in the macula or macula to equator region, so most of them are going to be easily photographed. Most of these are slightly larger that get referred to me, greater than 5 millimeters in diameter, but most of them are relatively thin lesions, about 1 millimeter thick. Most of them don't have risk factors. Most of them lack subretinal fluid or orange pigment. Most of them are your classic dome-shaped choroidal nevus with high internal reflectivity. And over time, we do see a pretty significant attrition rate of these, but more than half of these patients really do want either themselves or their provider wants them to follow up with us on the ocular oncology service. Looking at these over time, a very few of these do exhibit what we see as some benign growth, and then we have some higher risk lesions that do grow to melanoma or already presented as small melanoma that the patient preferred first to monitor. So how do those play out into this risk stratification model? So we see that we lose a little over 100 to the anterior tumor location, but the vast majority of the remaining tumors have few risk factors and are good photo screening candidates. We have about 50 that maybe need some personal review, and then we have a much smaller number overall that are poor candidates because they're high-risk lesions. So we were able to put that together and just in an automated fashion without my personal review, triage almost 70% of patients into eligibility for a photo screening pathway in this practice. And Rachel Tessum and Rachel Mulch, who are both interviewing for ophthalmology residency this year, wrote up our risk stratification model. And we've continued to put this into practice. So talking about teleophthalmology frameworks, we've heard already a couple different types of teleophthalmology frameworks today. We can have synchronous telehealth where you're actually talking to the patient, doing video or audio visits. We have hybrid models where they have some combination of virtual and in-person care. And we also have asynchronous telehealth where we do e-consults with remote review of information. And that's what I've been doing in my practice. In ophthalmology, we've seen, of course, these models work very well for things like diabetic retinopathy, where people will get a color fundus photo from a trained technician, and then they're going to be graded by somebody off-site, and they'll be told if they're good to go and keep monitoring or if they need to be referred for some sort of in-person evaluation. They do this in the United Kingdom and Singapore on a national level. They have excellent diabetic retinopathy screening programs. We don't have any national program in the United States, but there are regional programs that have adopted this same model. So this is something that's very applicable to choroidal nevus, and we have seen some applications like we've heard already today. We've also seen in the UK, they've used some photo screening and shown actually really good concordance between an in-person visit or an ocular oncology evaluation and a remote grader. And this has been prospectively validated that it's really relatively safe for these low-risk lesions. And we've seen also with Ezekiel Weiss's group looking at choroidal and iris nevi and image assessment and in-person versus photographic review by the ocular oncology subspecialist really agrees very strongly. So we have offered all of our eligible patients entry into this virtual photo screening pathway. We get photos that are a little more limited than what we do for in-person, but we focus very specifically on the lesion, and we can still get multimodal imaging. I customize the photo choices depending on the patient and the lesion. So if the lesion's very thin, then I will drop the ultrasound because we can see the full thickness on an EDI OCT. But I do often make those choices personally. And then I review these asynchronously. Results I give by patient portal, so I don't call the patient or have a video visit with them. I send them a message, and I generally do that very quickly, and I tell them when we're going to see them back. And I've been able to expand this so we have a wide network at Mayo Clinic of the health systems where they also have a lot of these imaging modalities. And especially when I don't need ultrasound, they're quite capable of getting good photos that are going to be up to my standard of care and within our medical record system so that they can actually get photos done closer to home without coming to Rochester, Minnesota at all. Anything that looks like lesion growth or worrisome changes, we're going to redirect the patient to an in-person return. And then we always make sure that we stress this is only for monitoring of the nevus, so you still need a general eye care provider to watch any other eye health issues. Most patients have been very excited to participate in this. I will admit it could be a result of my overbooked clinics. So once you've waited a very long time to see me, the prospect of not doing so again sounds very appealing. But it really does dramatically reduce the time spent in clinic for the patient. I would estimate probably on average more than 60 minutes worth of time reduction in my clinic. It's a lot more flexible in the scheduling. I don't have to be there. I can even be out of the country, but they can come when it's convenient for them to get their photos. And it's going to reduce the need to stay multiple days. It's going to reduce the need to take separate trips. If someone's coming for executive health visit, they can get this done the same day, added on at a more last minute notice than what I could add into my clinic. And so it really improves their ability to get their care on time and also improves access in my clinic to patients who really need to see me in person. Patients in my photo screening clinic, I've noticed, tend to much more tightly adhere to the recommended follow-up intervals, perhaps because of that convenience and not needing an appointment slot with me. So I've actually wondered over time if even for some higher risk lesions, this may be a good option because it's going to keep them on schedule better than in-person visits. And I'm pretty quick with giving these results back. I often do give them on the same day, but I do have dedicated time slotted for reviewing these images. So we know we've talked about some patients might have technology limitations, so that might be difficult for them to get their results by portal. Some of my older patients just cannot do portal access, so they may be better for in-person. Some patients want to see me in person if they have other eye issues, and we can't look at other symptoms unrelated to the nevus. And they can send me questions, but some patients might prefer to talk face-to-face. And I know if I wait a long time to read out the results, some of them do get pretty anxious. You need some good photographers so that you make sure that you're not going to fail to capture the lesion. And of course, you can apply other risk factor systems for stratification models, such as the MOLS system as well. So we've been working on patient satisfaction surveys and actually formally analyzing the reduction in wait time and the adherence to follow-up intervals. And I suspect in the future, we may lean more into fundus photograph only monitoring, especially in the future with assistance of AI models. We also need to work on insurance coverage issues when we're dealing with patients who are out of state, but the goal eventually would be to do a lot of this closer to home for patients once we overcome these challenges of crossing state lines. So about 70% of my practice were eligible for virtual screening, and this dramatically has improved my clinic efficiency and patient access, still investigating long-term outcomes and some reimbursement challenges with this. Thank you.
Our next speaker is Ezekiel Weiss, who's going to discuss impact of delayed referrals and the potential for improved outcomes with AI-assisted recommendations from fundus photos. Ezekiel.
Thank you. So we're going to take a step back to what happens prior to being sent to us and see if some of the technologies coming out now can benefit patients and improve outcomes. I have no financial interests that are relevant to today's talk. So just a one step back, this was mentioned earlier today, but about 5% of the population in North America will have a premalignant or at-risk lesion. So that corresponds to about 345 million people in the US with nevi. That's a lot of patients. Malignant transformation is extremely uncommon, about 1 in 6,000 if you were to average it. Early treatment reduces morbidity. Early treatment improves survival. What are the problems? Well, we can't even identify 6% of the population that have the nevus. We don't have that ability. And we definitely can't follow 6% of the population for growth very easily, as the last several talks have discussed. So what I'm going to talk today about is, can machine learning or artificial intelligence help us? And can we improve outcomes based on the current performance of models that are available now? So just to take a simplified understanding of kind of what's going on underneath the surface, what we are trying to identify is the patients who develop a second-order mutation or other abnormalities that lead to metastasis and melanoma. But we want to catch them at this point here and ideally treat them before those mutations or abnormalities in the molecular signature have been identified. And that's kind of our ideal goal in the long run. So what I'll talk to today is about delays in referral to care. The patients, we've all seen these every day, every week. Every month, we see a patient that we wish we saw earlier. If you look at the literature, there's about 7 significant studies about this topic, and I'll also discuss today our results from Canada that are still unpublished. If you look at these studies, you can see that between 20 and up to about 55% of patients referred in with a melanoma that required treatment had some sort of delay. And if we try to quantify these delay, it's anywhere from 4 months, 4 weeks, 3 months. But when you look at these older studies that didn't have, in my opinion, didn't do a great job dealing with the indeterminate lesion, if we look at it a different way about the time it takes till they receive standard of care, the actual result in our database is a 4.5 years of delay for a melanoma that requires treatment when there is a delay. And approximately 30% of patients that are referred late. So when you actually look about time to standard of care, when the lesion was first noticed or when symptoms began, it's quite significant, the amount of delay. So let's try to hash this out and see what this means for our patients. So there's multiple methods to quantify worsening outcomes. You can look at the tumor size increase from the delay, the actual time of delay, the genetic differences that occur over time, the risks of nucleation. There's many ways to evaluate this. For example, in our Alberta database, if you look at tumors detected and not referred at the first visit, when they first presented, there was a difference of 10 millimeters versus about 8 millimeters in basal dimensions. So obviously a difference in size. One of the really nice studies that came out this year from the Swedish group was a meta-analysis that looked at all the data out there and tried to find risk factors for delay in terms of time period. And rightfully so, because tumor doubling times vary depending on size of tumor. They divide it into the small, medium, and large categories of based on the COMS criteria. And what they found, for every 1 month delay in the small group, there's a 0.3 percentage point reduction in survival at 10 years, 1.8 for the medium sized, and 4 percentage points for the large tumors. So this is an attractive way to try to look at this to see impact. And we've looked at it multiple ways, but for today's 10-minute discussion, we'll just look at that. So if you look at our database, I'd say the last 900 cases we've had, about 17% fall into the small category, 70% into the medium, and about 15% into the large category. When you apply those numbers, 34% delayed in treatment, an average delay of 54 months. What does that mean? That means in, hard to see from here, in the US, there are 590 lives lost per year due to delays in treatment. In Canada, about 70. And this is not that we're not good enough to treat them. This is not that we're not good to identify them. They're just delayed in treatment, in referral to us. So can we do better? Can we help the primary eye care provider? And so I'm going to quickly discuss some of the AI work that our team has been working on the last 5 years and apply it to this data set and see what happens. So experiment 1, which we did several years ago, looked at, can we detect the nevus inside the eye or the melanoma? And what we found overall is a sensitivity is about 91% with our current database and a positive predictive value about 94%. So we can detect this lesion, but what's the problem with this is none of us want to follow 6% or 5% of the population. We can't do that. So let's try to get AI to do more for us. In a second study, we tried to see if the AI model can differentiate what I call the higher risk category, which is a high risk nevus of greater than 3 risk factors based on multimodal imaging and the Shields criteria, versus what we would diagnose as melanoma, and we categorize that as a high risk group. All these patients, in my practice, we discuss close observation, biopsy, early treatment. So that's why I categorize it as that group. The second group are the freckles, the low risk nevi, or the medium risk nevi, which almost all of them in our practice are observed over time, and therefore we put that in a second category. So can AI or our model differentiate the two? So what we found, this was, I think we published this about 1.5 years ago, is that we have about 89% accuracy in differentiating a high-risk lesion versus a low-risk lesion, which you can imagine how beneficial this is, because now we are saying that only the high-risk lesions need to be referred. So the workload on the ocular oncologist is much lower, and this is tenable. These patients, we want to see every single one of these high-risk lesions, and we would make time in our day to make sure that happens. So what happens if we apply this? What if if the optometrist took the Optos photo or the Claris photo, sent the image to the machine learning algorithm, and it came back with an answer, high risk or low risk? Well, if you compare the 89% performance versus the 62%, if I remember correctly off the top of my head, in the US, we would save 451 lives per year. In Canada, a smaller country, 54. And this is with the current level of performance. This is not the future. This is now. This is just Alberta's AI model. Things are going to get better over time. So in summary, machine learning is a promising tool to identify and categorize choroidal melanocytic lesions. It can improve upon the current performance levels and improve survival. And there's no question that over time this will get better. Our goal is to move all the patients to the 96% survival category. It'd be wonderful if that's all we saw and treated them at that point in time. And I think if you look at the number of patients that delay in care, there's a big room for improvement in what we do.
Okay, we're going to bring up Zelia Correa. Excellent. And we're going to start a panel discussion here. We're going to open it up for questions from the audience and also from the two esteemed moderators up front here.
You're more esteemed.
Yeah.
So I'll start. It looks like, so a couple questions. One, it looks like everyone is using the remote system for return patients, or are we also venturing into new patients who you may have maybe received a referral photograph of a very small thin nevus? Where does that fall? Where does that fall in liability? And if you're doing single modality, for example, instead of multimodality, could you miss something strange and odd, like an extraocular extension, but you're not seeing it?
Yeah, it's a great question. For my own practice, I've really tried to stick to the follow-up patients exactly for that liability reason. I want a first-time physical exam and multimodal imaging full panel so that I make sure that there's nothing unusual and make sure there wasn't anything peripheral that's not captured on the photographs.
Yeah, that's why that first visit takes so much longer than the follow-up visit, is you're really doing a thorough, comprehensive eye exam. By the time I'm done, I know everything about that person's eye, front to back, soup to nuts. So now I can sort of figure out how do we put them into a pathway for follow-up, but I would never feel comfortable doing an initial telehealth visit and then feeling like I know everything about what's going on with the patient's eye.
Yeah, I would agree too. We only do follow-ups, but I have to admit, during COVID, we did new patients.
Mm-hmm.
And I remember diagnosing squamous cell carcinoma of the conjunctiva in an Alaskan, because you didn't have to practice in your own state, but it's not that comfortable. But I did prescribe medications over the phone, never saw the patient.
In Canada, we have a third as many ocular oncologists per capita as the United States. So for the first 7 years of our doing our telemedicine, we always had an in-person visit. Now we're about 80% of the the first visits are telemedicine now. And so we have a triage letter. If it comes to a retina specialist and an elevated lesion, it says the word melanoma, they're seeing in person very quickly. If it comes, this is an optometrist saw this spot several years ago and is worried, they're seen in telemedicine actually more quickly because of better access. But we always do full modality in the first visit. We don't use the reference photo.
I think we're really at a great intersection here of timeliness, clinical relevance, and some scientific rigor, particularly as our clinics are becoming overwhelmed, as there's a greater use of wide field imaging out in the community, our optometrist friends, and suddenly there are lesions that were never there before. So this is super important for all of us, I realize. My question's more for Ezekiel, for those patients that you aren't seeing yourself, and then for the others who are having these patients come and follow up, where does the liability lie when, say, something else develops besides you watching this tumor? So diabetic retinopathy, that disc is being cupped. The patient is using these services without necessarily getting comprehensive exams. I mean, is that something we have to worry about?
100%. So it's all about balance. So for me, making sure that patients with diseases that are very risky are seen quickly are the most important thing. So for our first visit, we do a bilateral fundus photographs, we do bilateral OCT macula and nerve, we do intraocular pressure assessment, and we do an anterior segment photo. So that's my best attempt to achieve a rapid comprehensive exam without delaying patient care. Is it as good as an in-person exam? Not in a cooperative patient, but it's better than an uncooperative patient because the photographs are now better. So I think it's just a balance that everybody's going to find their way. And the literature, fortunately, when we've looked at the safety profile, so far we haven't seen any signal that we're missing significant things. But over time, I'm sure we're going to learn how to do this better.
Yeah, I think you have to keep the general ophthalmologist involved because you're going to miss peripheral corneal degeneration. You're going to miss cataract, cortical cataract, nuclear sclerosis. You miss it. You miss PSC. You can't judge the lens. You might miss glaucomatous cupping. You might miss mild diabetic retinopathy. So we always emphasize that they should see their regular ophthalmologist per routine. We're here to monitor the melanoma scar or the nevus.
Yeah, I completely agree. Every e-consult note that I write has a disclaimer at the bottom that says photo screening is for nevus monitoring only. Patients should still follow up with their general eye care provider. And I have actually been a bit of a taskmaster to the people who start these patients in clinic, saying, unless they're seeing another eye doctor that day for an exam and need both eyes dilated, you will only check vision and pressure and dilate the affected eye, so that it continues to send this signal to the patient that I'm not monitoring both of your eyes.
How long have you gone without physically seeing a patient in the system? Scott describes his protocol, about every year at minimum, maybe a patient could come back. Have you gone 2 years?
Yeah,
3
so
years?
after 2 years of stability, it'll be every 2 years for an in-person visit and every 1 year for imaging only for an appropriately low-risk lesion. And sometimes if it's like a freckle, I might do that right out of the gate.
Same here. Yeah, I've gone 2 years without seeing the patient in person, but usually when you do send them for that kind of photo screening and all of that, these are very low risk lesions, so it's very low threshold.
We've been doing telehealth since before COVID. So I have some patients that were 6 years that I haven't seen them in person, but I've seen them once a year on telehealth.
Yeah, us as well.
Yes, the same. I've probably made it to 3 or 4 years now that some of these patients are perpetually photo screened.
Because many European countries, like nationally, are screening nevi on new patients just by using Moll's criteria, which Burl D'Amato has used, and they're still being seen by their general eye doctors, but the lesion itself is only being monitored by images and then graded on severity, and if there's risks, then they see the patient. So a little bit different. So we have here at Stanford, we have a autonomous diabetic retinopathy AI-based screening system, right? So we have this set up in 10 centers and it's AI-based, so it gives you a reading. And then this gets to value-based medicine because in some ways it's great for all the reasons you pointed out, but for the system, like, in a academic facility, for the system, we're actually losing income. Right? Because we're not charging the visit and we're not charging, and forget all the savings for time and convenience. So you almost have to convince the powers that be to adapt this type of treatment paradigm that you are seeing more patients on the back end. And that was actually a bit of a challenge. Like with this system, like we save $800,000 a year to the system, which should be like applauded. But it's not because it's 800,000 less that comes into the system. So in terms of your practices, this gets to billing. I think Scott shared some billing codes. Is a lot of this being done for efficiency, and you just charge the technical fees for the scans, or are you charging your time as well, which is valuable?
You have to communicate to the patient in order to charge to bill the visit. And during government shutdown, we hardly saw Medicare patients because they had to pay out of pocket and none of them wanted to pay out of pocket. So we waited on that. So, but I just did an analysis and our Pennsylvania sites pay less for the doctor's opinion when they consult. That's why we do Zoom. We consult with the patient live. We do better in New Jersey. We get paid more to consult New Jersey.
Interesting. Yeah. In my practice, most of these patients, I'm billing the photos and I'm not charging the visit. And it's been exactly what you said. It took a long backlog of frustrated patients who couldn't get in to say, okay, I guess this is a great idea after all. If another eye care provider, even if it's an optometrist doing an executive health visit with someone visiting Mayo, sees the patient, they can e-consult me and then I can bill as an e-consult.
I have a question. Do you guys have any limitations as far as tumor location to do the photo screening? I mean, does it have to be equatorial or post-equatorial? Because I feel that sometimes it's hard for the photographers to get the pictures we need. I mean, they're feasible, but, right, you know, they're doing like one patient after the next. So I want to hear you all's opinion.
Yeah, for lesions that touch or in the ciliary body or involve the ciliary body, I still see those every visit for multimodal tumor imaging. But everything else, I think, is pretty.
Well,
minimal.
you mean anything that is pre-equatorial?
No. It can be anterior to the equator, but if it is contiguous with the ciliary body, I have to see it in person.
Well, you have a heck of a photographer. Let me know how we can cross-train.
You know, it's funny. I was talking to Ezekiel about this before we had the symposium. So we get a lot of the simple nevi and treated melanomas into virtual, and it's much easier on the doctor and on the patients. But it does make your clinics that you see patients in person much harder.
Worse.
Because then you're seeing all the complicated, complex patients, and Tuesdays turn into like a cloudy, dark day because, you know, you're seeing all these hard patients.
Be
So you
careful
keep
what
that
you
in
ask
mind.
for.
Yeah, that is a paradox. Well, we'll take one question, otherwise out of time.
I think that's for Carol.
Yeah.
For me, there's no additional cost, right? Because it's the existing office, existing equipment. So it actually makes me more productive because I'm making just as much money in half the amount of time. But go ahead.
Yeah, so we're in private practice. On Tuesdays, we will use our own office. I'm seeing patients in person, and we have our fast track virtuals coming in and leaving. So it's no more cost for me on Tuesdays. But on Monday and Wednesday, we see patients in Bluebell or in Cherry Hill. And I don't have the exact numbers for you, but I do think we are making ends meet. I'd have to do that analysis.
Excellent. Thank you for this great kickoff session. And if the next session speakers will join us up front, Celia, you stay put. Yeah, our next speaker is Dr. Michael Heiferman from Chicago to discuss integrated ophthalmic ultrasound enhancing usability and diagnostic utility. Michael.
All right, thanks, Prithvi. Excited to be talking to you guys about this device that we're developing here. So here's the funding for this device. Basically, ultrasound is very important to us. It's the gold standard for tumor measurement, and we use it for a lot of other reasons as well. But there are plenty of challenges when it comes to ultrasound in ocular oncology. We all kind of face these challenges to various degrees depending on where we're practicing. Certainly, the availability of a skilled ultrasonographer is hard to come by. Certainly, to evaluate these tumors, it requires a knowledge of the pathology. It also has a standardized labeling convention that is easy for us to understand, but if you're learning the convention, there's room for confusion there. And then there's quite a bit of inter and intra-observer variability that's been well documented in the literature. So co-registered reference maps are something that we're very familiar with OCT. So we all get a near-infrared reflectance image every time that we get an OCT B-scan. In fact, we almost feel uncomfortable if we don't have that reference image. It allows for precise localization of the B-scan. It allows for longitudinal comparison over time. It also allows for volumetric scans when we can line up the B-scans in order. So the device that we're developing is a combined ultrasound and wide field color fundus photo. So the goal is to produce an image like this, where we have an ultrasound and we also get a B-scan raster through that wide field photo. So some of the innovation that's needed to produce this type of device includes a transparent ultrasound transducer. So this has been first described in 2015. It helps to understand how ultrasounds work. There's a piezoelectric crystal that we introduce electricity to. It sends off an ultrasound wave, which bounces off our target. That bounces back to the crystal and produces electricity again. So basically the crystals produce electrical signal. And the crystals are typically transparent, but a lot of the other parts of an ultrasound are not. So there's the electrodes that send and receive electricity that can be transparent. And then as well as the epoxy or the surrounding cover of the ultrasound, it is not typically transparent. The other innovation here is the ultra wide field fundus camera. That's a contact camera, and similar to a RetCam photo. However, the field is quite wider. So the way we accomplish that is through pars plana illumination. It allows for a similar 190-degree field comparable to an Optos photo that's 200 degrees in a non-midriatic pupil. And this is a multispectral camera that we've already developed, but it would be a true color similar to a Claris image with this type of device. So if we combine these two innovations, we get the device in the lower left here that we've developed. On the far left is the gray ultrasound transducer, and that is the contact lens of the camera. So basically that acts as part of the lens system in the camera. And on the right is the first image that we took of a rat eye. This is a fundus photo, and then on the far right there, it's the A scan that corresponds to that location. Rats have very large lenses that take up most of the eye, so we see P1 is the cornea, P2 through P3 is the lens, and then P4 is the fundus. So there's quite a bit of application to this in ocular oncology as well as outside our field. The first one that we think of is an A scan to localize to the apex of the tumor. There's plenty of potential there to ensure that we know where we're shooting our A scan in order to get a standardized echography. There's also potential for echographically flat lesions. We've all seen ultrasounds that look completely normal, but we wonder if they just miss the minimally elevated lesion. There's also potential in multiple lesions. So for like retinoblastoma or uveal metastasis, where there's multifocal lesions, it could be helpful to confirm the location of the ultrasound is the lesion that we're looking at over time. And then certainly inter-observer and intra-observer reliability. So when we get an ultrasound from the outside, knowing where the sonographer shot that ultrasound can be very helpful. And then certainly for us, longitudinal comparison to make sure that we're looking at the same location over time. And there's also potential to create three-dimensional volumetric scans by lining up these scans even through a video and arranging those so that we have a volumetric scan of the tumor. However, there are certainly challenges with this device. Some of you may have thought of this already. We want our A scans and B scans to be nice and perpendicular to the tumor. However, what I'm presenting here is shot through the pupil. So it's hard to get a scan through perpendicular to a tumor if you're shooting through the pupil, if the tumor is in the anterior to the equator, for example. Also, we want our A scans to be through the pars plana to avoid the lens and cornea. However, our proposed device so far is through the lens and cornea. Potential solutions include displacement of the ultrasound transducer away from the center of the lens, as well as maybe an angle sensing articulating hinge that can sense the location of the A scan moving over time. Lost our, sorry, we're in the home stretch, so let's see if it clicks. No. All right, let's see. Okay, so the takeaway points, integrating a wide field fundus camera and an ultrasound certainly has potential clinical utility in ocular oncology. A portable ultra wide field fundus camera, as well as a transparent ultrasound transducer makes this feasible. And there's certainly challenges that remain, but there's opportunity to improve upon those challenges. And here's the team that's been working on this. Xingcheng Yao is the engineer, who's brilliant, develops really great fundus cameras for this work. And then here are my mentors and some of my research team. Thank you.
Morning, everyone. I think I'm sensing some synergy between this session and the last. So I'm going to talk with you about what we've been doing at OHSU with respect to ultra-wide field OCT imaging in intraocular tumors. I have no relevant disclosures except for some funding for this, but some of my collaborators do have IP associated with this work. So I am finally a member of the Cool Kids Club, and I'm here mostly to announce that. We at the Center for Ophthalmic Optics and Lasers are developing high-speed and ultra-wide field OCT imaging systems, validating the efficacy in capturing peripheral retinal images, and then looking at optimizing the design for improved imaging performance and broader clinical applications. I'm really excited about the work I'm going to show you today. This has been an evolving process working with our bioengineers, and the system I'm going to be talking about today is this 800 kilohertz 140-degree field of view OCT and OCTA device. It's an investigational handheld ultra-wide field OCT. We have a contact and a non-contact version, and the examiner sees a non-FOSS image during acquisition, which really aids in the image collection. We can do this on awake patients in clinic and in unsedated infants, and they do it awake on ROP babies. And this is the first work here. We're seeing my colleague, Pete Campbell, who's one of our pediatric retina specialists, familiar to many of you in the room, image an ROP baby with this system. This is a prototype, and he can get a really nice image here. You can see that neovascular ridge in less than 26 seconds and with minimal discomfort to the baby. So we can make these nerve to aura images and get these 3D visualizations, which are really exciting to look at. The neovascular ridge is shown there and the avascular retina. So I was really interested in using this technology in retinoblastoma, and that's where we first looked at tumors. So this was just a quick PMP that we published a number of years ago, showing that we could detect subclinical tumors, panel C, as well as larger regressed tumors using this ultra-wide field OCT system. We went on to show that our bioengineers could develop volumetric measurement techniques for retinoblastoma tumors. And based on this early data, successfully competed for an R21, where we're working with a physicist, Ben Vadcock from MIT, who's got a really fast laser, to develop a high-speed and ultra-wide field system where our goal is high-resolution aura-to-aura imaging. We're looking at capturing both large and small tumors and how well we can do it with this system, and then in calculating tumor volumes with ultimate goal of looking at RB screening and longitudinal monitoring of tumors and vitreous seeds. So I'm here to convince you, I guess, that OCT rather than color fundus photos might be the way of the future. So this is an example. This was the initial EUA for a child with a family history of retinoblastoma. I saw her at about age 2 weeks. You can see she has very blonde fundus, but there's an obvious macular tumor there, shown with that red arrow on the OCT-B scan. There was also a subclinical tumor, very hard to see on that photo. It was almost impossible to see on examination, with a yellow arrow just inferior to the infratemporal arcade. And then eventually a tumor appeared where that blue arrow is shown, which I couldn't see and we did not see on this OCT. So a couple months later, you can see where those tumors are because I've lasered them, which makes it a lot easier to find them. And we're looking here at maximum projection as well as a mean projection image on FOSS image. So the maximum projection essentially is looking at the peaks. It's looking at those highest voxels. We can see vessels really well, and it gives us like a topographical kind of on FOSS image. And then mean projection allows us, by doing averaging of the slab, to look at deeper areas. When we combine these two, we can get a pseudocolor projection where the maximum projection is in red channels and the mean projection is in the green channel. We get this really cool image where we can actually see, I don't know if I have a pointer on this, pointer? It works here, or works here, okay. There's a peripheral tumor scar here as well that's near the aura that we're able to capture. And we can create these cool three-dimensional images, which is really, really neat. But anyone who has ever looked inside of an eyeball knows this isn't quite what it looks like, right? So what is going on? The raw B-scan images from ultra-wide field OCT exhibit curvature distortion, kind of like we see in the ultra-wide field photos, and it limits our quantitative accuracy and 3D renderings. We've recently published on curve correction methods that were developed by our bioengineers to restore the geometric fidelity, and validated here with a 3D eye phantom showing relative errors of less than 1%. Then we went on to validate in eyes with tumors because we have imaging to compare it to. So based on CT and ultrasound measurements, we saw good agreement of our OCT measurements with about 3% error and a 6% error respectively for those modalities. And here's the images, these B scans before and after image correction with that curve correction. And here's what the 3D version of this eye now looks like, which is honestly very much like what it looks like in real life. And so I'm really excited about this technology and what it might mean. What about larger tumors? So this is a patient who came in actually the same day as that other young lady presented here with a group D eye. And we can see, unfortunately, the B scans aren't very bright here, but we can get images through there. This is after one intraarterial chemo session, we can see the retinal detachment is resolving. The tumor is now partially calcified, easier to see on those B scans. And when we look at the pseudocolor projection here now after 3 intraarterial chemos, we can see improvement in the tumor. We can also see though that this patient still has vitreous seeding. What does that look like? And I think these 3-dimensional images, and hopefully this is showing well enough for you, we can see both the seeding that's right near the tumor here, as well as seeding diffusely, superiorly and inferiorly. And what I'm hoping is that eventually we may be able to quantitate that. So shifting gears, we're also very interested in melanomas. And I think this has relevance to all of the really excellent talks that we just saw. Here we're looking at OCT in panel C and panel E. That's the pseudocolor image and then the B scan of this untreated melanoma. And this is a patient we've been following over time where we can see at the time of plaque treatment, and then 6 months later, 9 months, and 12 months later, regression of this tumor and resolution of the retinal detachment. We can measure it. And really exciting, I think, is that we can do volumetric measurements of the tumor over time so that we can really look at what's happening and have things move into a really quantitative way of monitoring these tumors, something that may be accessible and more easily interpreted, especially if we're doing things like telemedicine. I don't know that we're ready for monitoring treated tumors yet that way, but maybe someday. So I just thought these were also really cool, showing the evolution over time, the resolution of that inferior serous detachment and the regression of the tumor. So lots of exciting things happening. I'm eager to share more as they develop. I really want to acknowledge Dr. Yifeng Jian is our bioengineer in charge of this group, who does really amazing work. Shuibin Ni, Jakob Bekak, and Hao Shinkin are the primary folks working on all of this. And it's been a really fun time being one of the cool kids.
Thanks, Allison. Great stuff. Our next speaker is one of our abstract submitters, Zaid Mamo, is going to talk about polarization diversity OCT analysis and multimodal imaging of peripapillary melanocytomas. Zaid, thanks for coming.
Thank you. Thanks for having me. And it's hard to always follow a cool kid, but I'm a coil kid. So they stole the acronym from us, given that their lab started earlier. So we got the second best. We're cool kids. Coming from Canada, from UBC. And I have no disclosures, but I want to thank our funding agencies for allowing us to do this work. So I'm not going to belabor the point. The ultra-wide field OCT is the best thing ever. I'm sorry to all the aficionados of ultrasound or fundus photography. And I hope you can join me in admiring this image. They're not as nice maybe as Allison's, but at least they're non-contact, very compact systems that we use in the clinic. And I'll show you some pictures of that later. But I would say we're selling ourselves short by using OCT without extracting more data. And the reason we need more data, or at least we can get more data, is that melanin in itself can help us get more information with the OCT. Melanin polarizes light, and we can use that to delineate all the melanin within the RPE and the choroid and generate these nice images that can really help us there. We can see the beautiful choroidal vasculature, and maybe for a normal eye, it's not too exciting for non-retina specialists, but I love looking at the choroidal vessels. And we're able to acquire these images, readily and accessibly in a very small, compact, almost clinical grade, almost smaller than most OCT platforms commercially available. Why do we care? I'm just going to go some cases of maybe optic disc melanocytomas. They may not be as exciting as more malignant tumors. A bit of an interesting history about the name. Zimmerman came up with a name and then put it forward, and somehow it's stuck despite efforts across the years. His pathology shows intensely pigmented round to oval cells and bland nuclei. Very few case reports of macular transformation, and with kind of variable retinal choroidal involvement. Recently, there was some OCT work that looked at type 1, maybe type 2, with the top one being the more darker lesion, and maybe the lighter brown would be the one at the bottom, where more likely choroidal involvement. And this is kind of one of the cases that we looked at. This is a 38-year-old male of Asian descent. For heritage, we can see the we can see the darkening lesion there. Hypoautofluorescence, not really too helpful. But if we look at the on-fast PDO-CT, sorry, it's not working. Yeah, the on-fast PDO-CT shows us a kind of a largely low dope, very high melanin, and we can kind of scan through that through the spectral domain OCT, and that's in keeping with what we find. But what can we get from the PDO-CT? And if we kind of scroll through that, you can actually see confirmation of this being purely melanocytic or melanin containing, but right on top of it, there is actually a layer of retina that's not involved and actually contains no melanin. Okay, not really adding too much there. But let's add in and look at maybe a type 2, one with a choroidal involvement. Can we actually literally see the involvement of the melanin, and can we see it actually go into the lesion? And if we look at the regular OCT there, as we are close to the nerve fiber layer, as we're close in this very packed up area, everything kind of joins together, and we cannot really get it all clearly delineated. But if you look at the PDO-CT, you can see it right in the choroid, you can see go into the retina, and then maybe even dive back down. So almost similar to a U shape, similar to the kind of first lesion there. And this is just taking the cross sections there of the video, just in case it was going a bit too quickly. But we can clearly see just at the interface there, the melanocytic component goes right into the lesion or into the retina, and then back down on the other side there. I think I would say it's a totally novel image modality. Polarization or polarization sensitive OCT has been around for almost 10 years, but has not really made its way to melanocytic lesion evaluation. We've shown that in some, I would say those 2 cases of optic nerve melanocytomas, but we're actually looking at it into kind of uveal melanoma or uveal nevi, and these are some of the images that we have. I haven't shown too much here, but our early findings are showing that not every pigmented lesion on fundus photography is actually melanin containing. And there is a bit of a mismatch between the PDO-CT findings and the fundus photography that we're seeing, which may open up the field, like, what is truly is the lesion margin? Are we actually be able to truly delineate the lesion margin from fundus photography, or truly do we need a melanin-based imaging or kind of a molecular contrasting there? Other kind of qualitative metrics that we can find is that we can actually look into the melanin itself, or the DOPU signal longitudinally, and we actually see it varying over time. And can that be a biomarker for the future? And we had a case that I'm kind of regretting not showing it today, of a recurrent choroidal melanoma that required enucleation with same-day imaging, that actually the extension of the tumor did not show depolarization on DOPU OCT, only the original tumor. So the recurrence or the extension of the tumor itself actually contained melanin on pathology, but that melanin did not show on DOPU imaging or PDO-CT. I want to acknowledge all the collaborators. Actually, we collaborate with the cool kids as well. Yifan Jian was in Canada before going to Portland. And I want to thank Catherine Payton, the ocular oncologist. I'm a mere retina specialist. I don't claim to be an ocular oncologist. And these are my references. Thank you.
These papers are open for discussion.
Well, I'll start things off because, who amongst us doesn't like more gear? I mean, this is kind of exciting. For Michael, I understand the perpendicularity, the getting things off on the side, but you would think we are getting to a point where we could come up with some algorithm that takes into account angle of its incidence to create a volumetric measure or recreate the thickness. I mean, it's ultimately just geometry, right? I mean, you would think that we could come up with something like that.
Yeah, totally agree. I mean, IOL Master already does it. They account for the lens status and things like that. So it's definitely just a physics question. And I think historically it was thought that we should do ultrasound through the pars plana because it simplified the model. But now I think we very much could just do it through the cornea and lens very reasonably.
One of the questions is whether, we're looking at all these ways to automate doing multiple things with one instrument. And I guess, what we'd want is like perfect accuracy, like getting it just down right. Is the goal though, replacing us so that the imaging does everything that we would be thinking about and integrating that into some thought machine? Or is it just, are there referral, needs also? Like, when do you need to refer a patient from the community if you had this device versus actually needing this to be 100%, sensitive and specific?
Did I figure it out? I'm obviously not the brains of the operation. I think that, the concept of referral warranted disease is a really important one, and we use it a lot in medicine. And for me, I think I really struck by the first session in thinking about our technology and Michael's. I think there's a lot of synergy there where the goal really is to get an accurate idea of what's going on at that time. In that moment for the patient, and then figure out what do they need, and to make sure that we can continue to get reliable data. And then what we do with that data, I still think that we're valuable and our knowledge base is useful, and maybe eventually all the AI stuff will replace us. But for the time being, I think that it can only enhance our ability to support the ophthalmologists out in rural areas. I am also, like Lauren, seeing folks, all the places where in North Dakota they stop seeing her, in Montana they're coming over to me, and having a system. And what I like about what we're developing with ultra wide field is that ultimately it's going to have so many different uses that I think it may be very accessible, and it may be very it requires less skill in acquisition, and will continue to do so more. So if we can have these machines in every ophthalmology office, then I think there's a real ability to then use some of these techniques that our colleagues are developing to have further reach of our skill set.
I have a question for Allison. I love the OCT and the correction for the, kind of curvature and everything. I think those are really fantastic. What is the thickness limitation? Because I think that, Michael using ultrasound, he's going to have probably a broader, more deep depth of reach. So what would be the limitation of that? Or, the flip side of it, what would be the enhancement in terms of having that high resolution for the OCT?
Yeah, so right now there's a system with 12 millimeter axial resolution. There are some retinoblastoma tumors certainly that are right now a little bit too big for us to measure and capture fully. But what I've learned in working now for 15 years with this group is that if I say well, this is a problem, can you fix it? Eventually there will be a bioengineer who comes along and does exactly what Tom's saying, well, yes, we can definitely do that. And so I just kind of my role, I feel like, is in the practicality is in saying what I think would be useful and how we would use the technology. I think actually the biggest issue that I see is media opacity. And we're not going to be seeing through vitreous hemorrhage. We're not going to be seeing through a bad cataract. And those things could be solved. But I don't know that this is going to replace ultrasound or that we would want to. But I was really excited by your technology. I think that there's clearly going to be better things coming down the pipeline that will really help.
Yeah, I mean, they're definitely complementary. The axial resolution of ultrasound is only around 150 microns. So for, Carol's published on small tumors for OCT, and there's certainly value there, definitely media opacity as well. So I think they're very much complementary for that reason.
Tom, if you had one device that did two things. So Allison's device gives you OCT and it's a little bit of elevation, so you can get a sense of that. But the pseudo color is it's not great. It's really good. It's not great. What would you give up and what would you prioritize if you had, a 2